All right, welcome to this Clinical Explainer. Today, we're stepping right onto the wards for some high-yield surgical and medical rounds. We are going to tackle some of the absolute highest stakes, rapid-fire clinical scenarios you can face. Whether you're reviewing for boards, sharpening that clinical intuition, or honestly, just fascinated by the critical split-second decisions that actually save lives, you are in the exact right place. We're going to break down these complex cases and make the physiological why absolutely crystal clear. Let's get to it. Okay, let's dive right into this. Here are the 3 clinical wards we'll navigate today. 1. Trauma and critical airways. 2. Thoracic and pulmonary surgery. And 3. Vascular and gastrointestinal systems. Section 1. Trauma and critical airways. Picture this. A 24-year-old polytrauma patient rolls in with a severe pelvic crush injury after a massive high-velocity crash. You're thinking about using a pneumatic anti-shock garment, a PASC for temporary stabilization. So in which of the following clinical scenarios is using a PASC absolutely contraindicated? Is it a closed tibial fracture, a displaced humerus fracture, severe traumatic diaphragmatic rupture, superficial varicose veins, or a pelvic fracture with macroscopic hematuria? Take a second to lock in your answer. All right, if you guessed C, severe traumatic diaphragmatic rupture, you hit the nail on the head. The really crucial point here is the mechanical why. See, PSGs apply this intense external mechanical compression to the lower extremities and abdomen, right? And the goal is to auto-transfuse blood back into the central circulation. But if you have a diaphragmatic rupture and you inflate that abdominal compartment, you are sharply increasing intra-abdominal pressure. You will literally force those abdominal organs straight through that defect and right up into the thoracic cavity. That is going to precipitate catastrophic cardiopulmonary compression and acute respiratory failure. So the golden rule, absolute contraindications, include pretty much anything above the level of the diaphragm. Now, moving to airway management, here is a vital life-saving rule. A proximal tracheostomy cannot bypass a distal obstruction at the carina. Think about it. If you've got a patient with a severe upper airway obstruction, sure, a standard tracheostomy tube goes right into the proximal trachea. But what if that mechanical obstruction is all the way down at the carina? Right where the trachea bifurcates into the right and left main stem bronchi. In that case, a proximal neck tube does absolutely zero good. Air simply cannot reach the lungs. For those deep distal carinal obstructions, you've got to use specialized interventions, like a rigid bronchoscopy or distal stenting. Okay, let's talk central lines. When you're placing one via the percutaneous right internal jugular approach, what's the injury least likely to happen? The answer? Mechanical damage to the ascending thoracic aorta. It's actually at zero risk. And why? Because the thoracic aorta is tucked safely deep within the posterior inferior mediastinum, literally nowhere near your cervical needle trajectory. On the flip side, accidentally puncturing the common carotid artery, that is your highest risk, simply because the internal jugular travels right alongside it within the exact same sheath. And pneumothorax? Yes, it's a risk, but actually a much lower one here compared to a subclavian approach. Section 2. Thoracic and pulmonary surgery. Now, what's really interesting about this next case is the escalation. You've got a 45-year-old patient with a thick, loculated fibrinoepurulent pleural empyema. They've already had 5 whole days of large-bore chest tube drainage and fibrinolytics, but the serial x-rays are showing that the lung is completely trapped. It's just not re-expanding. So what is your next step here? Do you escalate antibiotics? Do you try pleurodesis? Or do you take them to surgery? You absolutely must escalate to formal surgical decortication. Let's walk through the 3 stages of empyema really quickly. Stage 1 is exudative. That's thin fluid, easily managed by a simple tube. Stage 2 is fibrinoepurulent, thick fluid with loculations where you need bigger tubes or fibrinolytics. But our patient, they're in stage 3, the organizing stage. The lung is physically trapped by this incredibly dense, rigid, fibrous peel. You literally have to go in and manually peel that thick fibrous layer right off the lung cortex, that's decortication, just to eliminate the dead space and get their respiratory mechanics working again. Next up, a classic diagnostic dilemma. We have a 55-year-old ex-smoker who had breast cancer about 3 years ago. She comes in and a routine x-ray reveals a brand new 2-centimeter solitary pulmonary coin lesion in her left upper lobe. What is the absolute most appropriate next step? Do you just wait 3 months and observe, run an MRI, or do you need to get tissue right now? You need tissue right now. And the correct answer is a CT-guided transthoracic fine needle aspiration, or FNA. You see, the real challenge here is figuring out, is this a brand new primary bronchogenic carcinoma from her history of smoking, Or is it a metastatic deposit from a prior breast cancer? A CT-guided FNA gives you 95% diagnostic accuracy here. And just look at the radiographic vectors. This is super cool. Benign coin lesions will often show these heavy, popcorn-like concentric rings of calcium. But malignant lesions, they're going to show asymmetric microcalcifications with these really irregular, spidery margins. And that actually perfectly connects to a fundamental rule of surgery for superficial soft tissue swellings, the biopsy tract rule. Fine needle aspiration cytology is the absolute gold standard because it prevents the creation of a large, contaminated tissue tract before you've even done definitive surgical planning. Think about it. If you jump straight into an open biopsy, you are risking contaminating entirely healthy tissue planes, which is going to make your definitive surgical resection a whole lot harder down the line. Okay, mucoviscidosis. He's probably heard this historical term, but it's actually the pathognomonic name for cystic fibrosis. CF, as we know, is caused by a CFTR gene defect that completely wrecks chloride transport. But mucoviscidosis is literally the perfect descriptive term here. It describes exactly what happens. You get a total lack of hydration on epithelial surfaces, creating this abnormally thick, highly viscous mucus. It's a devastating cascade. It plugs the pancreatic ducts, causing acinar atrophy and malabsorption, and it heavily plugs the lungs, leading straight to progressive bronchiectasis and respiratory failure. Let's shift gears to VATS sympathectomy for patients suffering from severe, totally life-altering primary palmar hyperhidrosis that just won't respond to meds. This is a game changer. For isolated palmar sweating, we target and ablate the sympathetic chain at the T2 and T3 levels. If it involves the axilla, we add T4. But pay attention here, there is a massive danger zone, the T1 stellate ganglion. If a surgeon accidentally injures T1, you disrupt the sympathetic ocular fibers. Boom, you've just caused iatrogenic Horner syndrome, meiosis, ptosis, and anhidrosis. T1 must absolutely be preserved. Quick anatomical point here on thymoma resection. If you have a patient with myasthenia gravis and a benign thymoma in the anterior mediastinum, the absolute gold standard approach is a median sternotomy. Why? Because this symmetric anterior incision gives you unparalleled anatomical exposure. It is structurally essential so the surgeon can safely clear out the thymic horns while meticulously identifying and protecting both of the lateral phrenic nerves that run right along the pericardium. Let's move to our final ward and see how this builds our clinical intuition. Section 3, Vascular and Gastrointestinal Systems. All right, check out this presentation. A 60-year-old guy just one day post-extensive anterior wall MI suddenly experiences this agonizing, poorly localized mid-abdominal pain. But here is the wildly deceptive part. His abdomen is completely soft. It's non-distended, barely tender. Yet, his blood pressure is starting to tank. What is your absolute best diagnostic choice here? If you said mesenteric angiography, you are spot on. This patient is showing the absolute classic textbook hallmark of acute mesenteric ischemia. Pain way out of proportion to physical findings. He's in agony, but his belly is soft with no obvious peritonitis. And the pathophysiology tracks perfectly, right? He formed a mural thrombose over his fresh MI, it embolized, and it totally occluded his superior mesenteric artery, starving his small bowel of oxygen. You have got to get a prompt mesenteric angiography or CT angiogram immediately. Let's look at a timeline critical scenario. A patient comes into the clinic exactly 4 weeks after a transhiatal esophagectomy. He's complaining that he's progressively losing the ability to swallow solid foods. But here is the crucial clue. 0 fever, 0 signs of systemic sepsis, just the dysphagia. So what postoperative complication are we most likely looking at? It's a benign anastomotic stricture. The timeline is everything here. An early anastomotic leak happens within the first 3 to 7 days, and it is a total septic disaster. We're talking high fever, leukocytosis, the whole shebang. But at 4 weeks out, progressive dysphagia with no infection strongly points to a fibrotic healing cascade that's literally created a structural scar or stricture right at the cervical esophagogastric anastomosis. The good news is we can usually manage this pretty easily with sequential endoscopic balloon dilation. Okay, manual exams. You have a patient with severe superficial varicosities, and you decide to perform the classic Brody-Trendelenburg test. You elevate the leg to empty out the veins, tie off a tourniquet at the groin, and ask them to stand up. What exact mechanical parameters are you isolating and evaluating when you do this? You're functionally testing the competence of both the superficial and the perforating venous valves. Let's break down these Trendelenburg pearls.
Because the mechanical logic is awesome. If those varicose veins fill rapidly from above only after you release that groin tourniquet, that tells you the saphenofemoral valve is incompetent. However, if those veins fill up rapidly within 30 seconds before you even release the tourniquet while it's still clamped tight, that means blood is leaking backwards from the deep system, and that confirms perforator incompetence.
All right, as we wrap up this explainer, I really want to leave you with a provocative question. Are these exam pearls we went over just multiple choice trivia, or are they literally the critical margins of error between a routine recovery and a complete surgical catastrophe? Knowing why a PASG on a ruptured diaphragm causes cardiopulmonary failure, or exactly why a T1 sympathectomy ruins the sympathetic ocular fibers, guys, this isn't just textbook theory. This is the core physiological intuition that defines a great clinician. Keep learning, keep questioning everything, and I will see you on the next round.